All right, it looks like the clock just turned to 10:03, so good morning, everyone. Again, thank you for joining our prior authorization overview training for our PT93 substance use treatment providers. My name is Susan Harrison, and I will be hosting today's presentation. We also have joining us Alyssa Drucker. Both of us are provider field reps for Gainwell Technologies, which is the fiscal agent for the DHCFP. Speaking of DHCFP, we have Beth Scott, our policy specialist, also on the call, as well as our medical management team, Joanne and Tracy. So thank you so much for the support and for joining our training today. I do want to let everybody know that today's session is being recorded and it will be posted to the Nevada Medicaid YouTube channel playlist tab. You can also refer to other substance use training videos that are related to enrollment in the same playlist. So that will be posted out there for you in about a week or two. I'm not sure how long it takes to transfer a recording to a YouTube video, but we will have that out there for you as a resource. We will go over instructions on how to locate those resources a little bit later on in our training. So we do expect today to take about an hour. I have scheduled an hour for it, so we're going to have a lot of information. We're going to be covering a lot of resources, but first I'm going to go ahead and start sharing my slides so we can go through those and get started. So as I mentioned, today is our prior authorization overview training. So the objectives we're going to be covering today are outlining the prior authorization basics, locating the required forms for submitting that prior authorization. If we have time, we'll navigate the PA submission process. I don't think anybody on this call is new to requesting those, but if we have time, we can do that as a demo at the end. Discuss instances that might arise after submitting your request, technical denials, reconsideration requests, those types of things, and locating additional resources and contact information for Medicaid. So before we jump right in, how do we get reimbursed for these services? So under your 17215 contract, you are familiar with how to request those prior authorizations, the prior authorization requirements. With the new 93, those authorization requirements did not change for your ASAM levels 1, 2.1, and 2.5, but we did add that new ASAM level of care 3 for the residential treatment. So we're going to be covering those types of scenarios today. I did want to let everybody know that if you are enrolled as a level 3 provider and you are going to be submitting those residential treatment codes that just got posted in that web announcement 3467, those codes are available for you in the system. You can request prior authorizations on those. You can add that as your service or your service code. One thing you need to make sure that you're aware of is that once you get those prior authorizations approved and you're submitting claims, if your claims are in the system prior to 1/21 of 2025, that's later on this month, they will suspend. Those code rates are being built in the system now. They have not been released and not everything is up to date. However, the codes are available for you to request the PAs. You just won't get paid until it runs through the system processes and it goes live in actual system for payment, which won't be until 1/22. So if you have a claim on file and it suspends for the 3 codes, it will automatically release for you on 1/22, go through that week's financial cycle, and then appear on the following week's remittance advice. So I want to make sure that everybody's aware of that, so you don't think that you're not getting paid for these services or there's going to be a recycle. They will automatically process and release if they're in the system prior to the 1/22 date. Okay, so what is an authorization? It's an approval from Nevada Medicaid that may be required before a service is rendered for the service to be covered under the recipient's benefit plan. And it's used to determine medical necessity only. It is not a guarantee of payment. And then when one wouldn't be necessary, it's required when policy and billing guidelines dictate that it is required. What is an adverse determination? So an adverse determination is when it's denied or reduced based on the request that was submitted. If you have a number of units that was reduced or a service that's reduced, or it's completely denied for medical necessity, that would be an adverse determination. Technical denial does not qualify as an adverse determination. I mean, it does technically, but you cannot do a reconsideration for those. So if it's a technical denial, that means there was an error in the information that was submitted either on the FA11D form or on the portal. You'll get that technical denial saying what needs to be corrected, and then you have the opportunity to resubmit. An actual denial is when it doesn't meet the medical necessity criteria. And a reduction in service, again, is what the requested service doesn't fully meet the medical necessity. So it's either reduced in units or the actual service is reduced. If you have multiple codes on your claim or your PA request, we may reduce for one service. What do we do with those adverse determinations? Well, you have two opportunities. You can either request a peer-to-peer review. That's when your requested service has been denied or reduced for medical necessity. And so the peer-to-peer is to get on the phone with a clinician or a physician reviewer to determine why that denial or reduced service was applied and how they came to that determination. So it's for clarity purposes only. It does not qualify as the reconsideration request process. So it's just for the clarity on why it was reduced or denied. You can do those within 10 business days of the actual adverse determination notice. You would send an email, and I will get you that email here. It's right there at the top. It's that nvpeer_2_peer@gainwelltechnologies.com. So be very careful that you get these underscores here. They're not dashes. Then you also have the opportunity to do a reconsideration request. So that's once it's requested, you cannot go back and do a peer-to-peer. So you can do the peer-to-peer first and then a reconsideration. But if you go straight to reconsideration, you can't go back and do a peer-to-peer. All right, so reconsideration is a written request to re-review a denied or reduced PA request. We do have a specific form for that. It's your FA29B form. If you're doing a reconsideration request, those are to be uploaded through the portal using the file exchange. Those instructions are at the top of the FA29B form. They, again, are not available for technical denials. Then the timeline to do a reconsideration request is 30 calendar days once you receive that adverse determination notice. Again, you'd use that form FA29B. And your documentation should be something that was not included in the original request that would justify the reason that you're requesting the service that was outside of what you originally requested. So you can't upload the same documentation. It has to be something in addition that's justifying why you're requesting that reconsideration. So we have different types of requests for our prior authorizations. Your first request is going to be your initial request. That's when you have the 15 calendar days to submit that request from the date of service, or you can do it I think it's 5, we'll have to look at the billing guideline when we get there. I can't remember the days specifically, but if you're doing it prior to, you would have that initial time frame to submit your initial request. Once you have that initial request approved, and if the patient needs to continue services, you can do a continued stay request or a concurrent review. That's when those recipients require service dates that were not requested or approved in the initial authorization. Inpatient hospital does not qualify, so it must be received by Nevada Medicaid by the last authorized date. So that's your second little bullet here. And it looks like, Deanna, you have your hand raised.
Hi, this is Jackie. Also, I'm sitting here with Deanna. So I just want to clarify. So we would submit for a 30-day auth. We are a 45-day program. So then we would just need to ask for additional units prior to that 30 days ending for an additional 15 days, since we're a 45-day program.
So we are going to be looking at those timelines for the prior authorization approvals, depending on the ASAM level of care you're requesting. We will be covering that so that you'll know when your continued service request should be received by.
So everybody's already okay.
So I will be covering that here in just a few minutes, okay? That way you'll know exactly where to go for that resource.
Thank you.
You're welcome. Okay, so unless specific requirements are contrary to these instructions outlined in the billing guide, those you'll use for your specific provider type, which is the PT93. You'll follow that billing guideline for the continued stay timeline and initial request period. And we will be covering that here in just a moment as well. Okay, so we are going to go out to the Nevada Medicaid website now. Okay, so we're navigating out here. I'm going to take you through some of the resources. So an unscheduled revision, you're going to use your FA11D. So there were many people who got that answer right. FA11D is for your unscheduled revision. And FA29 is when you do a data correction. A data correction is a technical or clerical error. It's not a medical necessity error, request. So unscheduled revisions are for medical necessity changes when you have a change to a recipient's condition when you already have an approved prior authorization in place. So we're going to cover that a little bit more when we go through the forms, but I just wanted to see if we understood what form to use for unscheduled revisions. So again, FA11D, because it's going to be in addition to or in replacement of an existing authorization that's already in place. FA29s are to change something on there that's either a unit or a data service or an NPI or something like that. Okay, so the first place I'm going to go today is to our billing manual, so we can go over where to find the instructions for peer-to-peer, reconsiderations, retrospective reviews. For the billing manual, you hover over providers here, and then select billing information. And then we'll scroll down to the middle of the page here, and we're going to click on the billing manual link. And we'll open up that PDF document. Okay, so I'm going to go right to Chapter 4 because that's where the prior authorization information lives. And you can do a control find with your keyboard and look for keywords. It'll take you to all of those words that are reflected in the manual itself. I should have just chosen authorizations, but okay, so back to our table of contents here. Oops, let me go back one. Okay, you can either hover over the Chapter 4 and it's got a little hand that'll take you right to that chapter because it's hyperlinked. So we'll go ahead and go there. In this section, it's going to give you the timeline for submitting prior authorization requests for services that are not substance use or behavioral health. Those we're going to refer to the billing guideline for, which we're going to cover next, but I just want to go through this section first here. So you do need to fill out that FA11D form. You need to create that prior authorization request through the portal. That FA11D and the portal information should match. So you need to make sure that your date span is correct, your units are correct, the service code is correct. And for all of the prior authorizations under your provider type 93, they should all be requested under the group NPI. You do not list an individual's NPI on your PA request. That will allow for the group to use multiple different servicing NPIs for the claims when they're actually submitted. We want to make sure that you have that flexibility. Should you have somebody call in sick or somebody on vacation, somebody needs to fill in, you have that flexibility to use multiple or different NPIs on your claims. So again, you have to have that FA11D form filled out. You do your request through the care management tab on the portal, filling in all of the required fields. And your timelines are also listed here. But again, we're going to follow the billing guideline for that. And that's exactly what it says here. So it does tell you to refer to your billing guide. For these provider types, it has not been updated to reflect 93, but we know that the 17215 is sunsetting as of March 31st. So we'll be adding the 93 verbiage up here. Okay, here's where it covers our continued stay requests. And that would be covered under the section here, which we already talked about. If you have a retrospective authorization request, I'm sure that we are all familiar with what qualifies as a retrospective. That is only for those individuals where treatment has already started and they become approved for Medicaid during that episode of care. And you need to go back and request that retrospective authorization to the beginning of when you started treating that patient. You have the opportunity to go back. You can request those retrospective requests within 90 calendar days of the date the decision of the Medicaid eligibility was, and you would get that date of decision out of your portal when you're verifying eligibility there. You need to make sure that those are requested as retro BH as your process type when you're doing those on the portal. The other thing that would qualify as a retrospective authorization is when you have, if you're going through revalidation for your group NPI, and you might term during that revalidation process. Once you're reinstated, you have an opportunity to go back in and request a retrospective prior authorization. and you have 90 calendar days to do that from the date that you were reinstated, you do need to make sure that you're including a copy of your revalidation approval letter so that the team can review those dates on there to make sure that you're within the time frame. That's important for you to include that as well as your FA11D information. So that all that information lives here. And scrolling down here a little bit further. So after submitting your request, if it's incomplete, we will pin that back to you. We give you 5 business days to submit that requested information, or we will issue a technical denial. Here's where we talk about the unscheduled revisions. If you have a modification to clinical information, that's going to be submitted on your FA11D, and that kind of goes into the timelines here. You want to make sure that those are submitted prior to you actually rendering services. So I know that sometimes you won't know until you actually are scheduled to see that patient that day, but that unscheduled revision should be submitted that day for the changes if that's going to be at the appropriate process. You need to make sure that you're doing it before you actually treat that patient so that you get that approval in place. You cannot backdate an unscheduled revision. And here, if you're correcting the non-clinical information, that's where you're going to use your FA29 data correction form. So that kind of goes into scenarios here for that. If you are wanting to know about approve requests, you're going to get that notice of decision letter that'll be mailed out to you and a copy to the recipient. And here's where it talks about your adverse determination. So it goes over the different determination types. That's your technical denial, your regular medical necessity denial, or the reduction in services. Here's instructions on your peer-to-peer. So you guys are probably all real familiar with this. I'm not going to go through it like line by line, but just so you know, it's out here in the billing manual, chapter 4. You should be able to find anything that you need. So I'm going to go ahead and close this out unless, Alyssa, there's any questions specific to billing, the billing manual.
Just a quick clarification for PT93, if you find yourself in the situation for retrospective authorization, the process type would be BH rehab. So retro BH rehab if it's a retrospective request, but if it's a regular request, it's BH rehab.
Thank you for that. All right, so I'm going to go ahead and close out of this. And we'll go back to our resources page. We're going to go ahead and jump down to the bottom of this billing information page and go into our billing guideline by provider type. We will use the PT93 707 billing guide as our sample for today. If you are a residential treatment 704 specialty, of course, you'd use that one. And then your specialty 708 for opiate treatment, you would use that one. But we'll use this one because it has all of the levels of care here. And hopefully this is big enough for everybody to see. I can make it a little bigger, I think. Hopefully that's a little better. So on your PT93 billing guide, under the policy chapters that are hyperlinked up here in your rates pages, it goes right into your authorization requirements. So the 2 forms that can be used for substance use providers is our FA11D. That's going to be for all of those ASAM level of care requests. And then if you have to happen to have any laboratory services that are part of the treatment, and you could use the FA6, which is your outpatient med surg for any of those drug screening codes. Those are a separate submission than your FA11D. They cannot be submitted together. They must be done independently through the portal and each form. So if you do an FA11D, you would do it under the BH rehab type or BH retro rehab. And then if you do drug screenings, you'll do an FA6 and create one for the outpatient med surg process type and upload that separately. So again, 2 separate submissions, 2 separate PA numbers. You do have to also bill those claims separately so you can capture the correct PA numbers on those claims for those services. Let's see. So we have some authorization requirements here. I'm not going to go through it all, but request timelines, that was a question that's already come up. You have your initial requests. Those can be submitted 5 to 15 business days before a start date of service, or no more than 15 calendar days after the start date of care. Once you get that initial approval in place, any continued service requests that the patient needs to continue care, those must be received by Nevada Medicaid by the last authorized date and no more than 5 to 15 days prior to that last authorized date. That's all captured here for you. Go into our unscheduled revisions. Those need to be, like I explained, they cannot be backdated. They must be submitted on or before the actual service is provided. and it has to be within an approved PA period. And then your retrospective requests, we just talked about that. Okay, we're not going to cover the Medicaid assisted treatment here. You can go ahead and read through that if that applies to you. What I do want to go over is this grid that has been an amazing help for our providers and for me. I refer to this all the time when somebody asks me if a code is covered and who can provide that service, since we do have those multiple provider types that can link to a PT93. It does list here what provider types can provide each service and what level of service that qualifies for. So if you have, for example, an H0005, we'll go to the bottom here, you can see all of these provider types that can render that service and what level of care it falls under, which would be your level 1 outpatient services or your level 3 substance use residential services, level 3, 3.5, and 3.7, I think is what we're doing. It does not tell you on here if PA is required for these services. You do need to check that separately, but you'll check it based on the rendering provider's provider type. So you can't check it under substance use PT93 because it's not going to necessarily bring back or return the correct information. You want to make sure that you're using, when you're checking authorization criteria and fee schedule criteria, you use that rendering provider type specialty for the rate reimbursement and for the authorization requirements. So there is our billing guide. Any questions on the billing guide before I close it out, Alyssa?
It looks like one just popped through from Danielle in the chat. Auth before services rendered for all Medicaids, ? Correct? I think this is asking, is authorization required prior to rendering? Yes, if a prior authorization is required, you need to have that approved in place prior to rendering services.
It looks like we have another question as well. So on the billing guide updates to include those level 3 services, those cannot be posted and updated until they're actually available in the system for providers to access. So again, I mentioned that 121, 122 date later on this month. Those billing guides should be updated and ready to be posted either on or around those dates. So you'll be able to reference the codes out there. In the meantime, there is a web announcement that was posted to include those rates for those 3 residential codes. Let me see if I can find that for you. I just had it this morning, but we'll go to the web announcement so you can find that. So we'll go back to providers and view all web announcements. And then I'm just going to search by residential. And so it is the next one here. So web announcement 3487, thank you, Alyssa, does give you some information about the residential treatment codes. It tells you the codes, the rates, and then it says that they'll be ready by the end of 2024, but we did have to bump that back a little bit. That's why we're targeting that 122 date. So that should be available for you, as well as the billing guides also will be posted then, and the claims will release if they're in the system. Okay, any additional questions on that?
It just looks like Deanna has her hand up.
Okay.
Hi, this is Jackie again. Just another question that I thought of. So, what about, so I was looking at like who can render the services. What about case management? Case management, is that part of that rate, or?
What is the provider enrolled as if they're a case manager?
That's what we're asking. Like, what do they need to be enrolled as a case manager? And that's a part of their stay. So just, I guess, documentation and who's allowed to do it.
Beth, do you want to take that question, or we'll have to take it as a takeaway? Because I think that if you're a case manager, you need to have an NPI, you need to be enrolled, and it's going to depend on your licensure, your whatever criteria it is for the PT93 specialties, if that's in fact what provider type they should be, or any of the other specialties that can link.
Gotcha. Okay.
Can we actually link TCMs? Because from the very beginning, it doesn't give us the option.
I'm sorry, I'm having a hard time hearing.
I'm saying is it doesn't give us a provider type, or I'm sorry, not a provider type, but for the TCMs to be enrolled for the PT93.
Okay, so if there is no provider type for them to be enrolled, then they should not be enrolled as a provider and you can't bill for it. So if they still provide the service, that's up to you and how
Okay.
your program runs. That's not something that's dictated by Medicaid, but there would
And
be no way to bill for their services.
Okay.
targeted case management is a PT54 group provider. Groups cannot link to groups. Targeted case management is not an individual provider type. So
Okay.
in order to qualify for PT54, there is specific enrollment and billing requirements.
Okay.
If you want to reach out to Nevada Provider Training after, we can provide those pieces of information. But essentially, targeted case management is its own provider type, and it is a group provider. 93 is a group provider, and groups do not link to groups, and they don't overlap that way. So hopefully that kind of helps clarify visually a little bit of like what we're talking about. I'm not sure if you're asking about how targeted case management might be carved out of those 3 residential codes, because those are bundled rates.
Right. So if you're billing for residential codes, those 3 codes that were just approved, H0011, 0018, and 0019, those are bundled rates. So you can only bill that code for any given day if you're doing the 704, 713 codes, the residential treatment, or your 707 level 3 services. So you can only bill those codes once a day. It's not, you can't get separately reimbursed for anything else on those days if you're billing those codes. Hopefully that clears it up. Heather, are you asking a question about them being capitated services or?
No, ma'am. It was
Okay.
just a statement.
Okay,
I do
thank
have
you
a
very much.
question though.
Okay.
My question is, even though that you guys haven't added the bundled rates to the Medicaid fee schedule just yet, are we still able to authorize for them?
Yes, yes. So that was my point that I made a few minutes ago about billing for those services. You are able to request the services through the prior authorization piece through your care management tab. Your request, you can put them on the F11D. They are being reviewed. We have had some already. They will be they'll be reviewed and either approved or an adverse determination will be made. You'll know why. And then those, once you build a claim, the claim will suspend in our system until January 21st. Because the code rates have not been loaded completely into the system. Once they are done and they're put into our production environment, which is where you submit your claims, they will be released and they'll go through that week's financial cycle. So the tentative date is the 21st. You will then see your claims release on the 22nd, and then they'll pen for that financial cycle for that week and then be on the following week's RA.
Perfect. Thank you so much.
So we are encouraging providers to follow that process. If you have services that you need to bill for residential, that way your claims are there. You don't have to worry about billing them all on the 22nd. They'll just be there. They'll automatically release.
Thank you. I appreciate you.
Yes. Any more questions, Alyssa?
Yes, there's one question in the chat from Jennifer asking if providers can bill H0019 and then bill separate codes if they see the nurse practitioner.
I'm going to defer that question to Beth. I don't believe the answer is yes. I think that you can only bill your bundled rates and you can't bill separately for any other services if they're in the level 3. But I'll defer to Beth.
So thank you, Susan, for passing that question. Jennifer, just to clarify, if the recipient is in your program that's billing H0019 code, I can't remember off the top of my head if that's PHP or IOP. I'm sorry, 3.1, sorry.
It's 3.5.
3.5. So if the recipient is in your program, in your 3.5 program, and they need to see an APRN for a medically necessary service that is outside of the 3.5 services, then the answer is yes. There was a web announcement that went out following the prior authorization requirements for the other services. You would need to submit that request for the additional medically necessary services.
I'm going to look for that web announcement now so that we can pull that up for people.
Okay.
I don't remember the exact number. think it was before this. I can't remember the number. I think it's on my list. Let me get that web announcement number for you, Jennifer,
look
and we
forward
can
to it.
post that in there. Thank you very much for bringing that question up. It's a great question. And thank you, Beth, for clarifying that. So let me go to the next thing that I want to bring up before while we're looking for that web announcement number is to let you know how to bill those level 3 claims. We did have a question come up from a provider that asked what individual rendering provider is supposed to be on the claims for the level 3 services because they see or could see a multitude of providers for that day. And so the response to that is that you would use the individual provider's NPI that has oversight to that program or to that individual's plan of care. And then you document in your documentation who actually provided or facilitated the treatment. So hopefully that makes sense. If not, then go ahead and put your question in the chat or raise your hand and we can further clarify.
There's a question in the chat from Deanna asking, what if we have to bring them out? Can we bring them to our CCBHC? Are you saying discharge from the PT93, Deanna?
No, like because if our APRN works at the CCBHC and they need to have services done, can we bring them to our CCBHC and take them out from our residential for that day or whatever for the appointment? So I know like earlier you guys said we can't bill, but if we bring them outside of the residential for that service to be rendered, can that service location be a CCBHC?
So would that be because your services are not available in your residential?
Correct.
So there is a part in the MSM 4100 that does cover that, and we'll go over that because that's my next topic of conversation. So we are going to cover those sections.
Okay. Thank you.
Yes. Angela, did you get your question answered?
Sorry, it's just easier for me to
Sure.
unmute. When you
Yeah.
explain the billing, can you just
Yes.
explain that one more time? I just want to make sure it was a little fast in my brain. I just
Sorry
want to
about
hear
that.
it.
Yes.
It's okay.
So the question is, what individual do you use on your level 3 claims? Because they could be seeing a multitude of providers on that same day. And since it's only a bundled rate, you can only use one NPI. So the individual NPI that should be used is the one that has oversight to the program or the individual who has oversight for that treatment for that particular recipient.
Got it. Thank you.
You're welcome. Thank you, Beth, for putting that in there. I am displaying it also on my screen. That 3486 talks about other outpatient services that are medically appropriate while they're in a different type of program. This one really only talks about IOP or PHP, and other services might be necessary. So Beth, I'm not sure if the intent was to include residential as well, but I do know that we cover that in MSM 4100. So I will pause here for just a moment in case you want to clarify or if there's any other questions.
Susan, there's one more question in the chat from Jennifer SUT asking specifically for groups that all the facilitators are not licensed, if they can still provide the service. For example, they have psychoeducational groups that community partners provide or staff that is not licensed.
So when you're doing your billing under your PT93, you are required to have any individual that provides a service to be enrolled with Medicaid and linked to your group. So you can only bill for services that is a qualified individual for PT93 and that is linked to your group. Anything else you wouldn't be able to bill for. Does that answer the question? So I'm going to go ahead and share web announcement 3497. Alyssa, if you want to put that in the chat. This one has that the takeaway document that was part of the workshop training for enrollment, that it shows what provider types can link to a PT93, and it's actually on page 2 of that web announcement. So here, this was the takeaway document that was part of that workshop, like I mentioned. You can access this resource. It is on our provider training page, but these are the individuals that can link to a PT93 group, and those that are highlighted or bolded can be qualify as the clinical supervisors as well. So I'm hoping that that will be helpful for you in answering your question as far as what services for those individuals who are not licensed or that are not enrolled. You can't bill for them. And so if you want to come off mute and kind of clarify what you're asking, because I'm not sure I understand. If you're still referring back to your APRN scenario, if that's what you're trying to describe, I'm not sure.
Okay, can you hear me?
Yes.
Okay. Um, so for instance, like if I'm billing like the bundled rate for a client, so 80019, I'm going to bill that under either our, let's say, clinical supervisor or whoever the primary counselor is, and they are provider type 93. And then so throughout the day, they're going to have many, many services. So if like the requirements, you know, say the 25 hours with the 10 hours, if we have that, but the additional one, like we wouldn't bill separately for, let's say, a group that our nutrition person does on nutrition or health and wellness, but it would still be like a service they received that day.
So that should be documented in your chart notes, but you wouldn't bill separately for the services because it's if it's inclusive of the services that are provided in the 3.5 ASAM criteria, then you wouldn't be billing separately for those services. It would just be documented in your chart who's providing that service.
I guess that's what I'm trying to clarify. Like, are we going to get a kickback, let's say, because all those documented services that we say we're billing for, one of those people are not like a Medicaid provider?
So the description of these codes that are listed in the web announcement, like just for example, H0018, behavioral health, short-term residential, in little description, it says non-hospital residential treatment without room and board per diem. So anything that is being under that umbrella of that behavioral health, short-term residential service treatment is included in the bundled rate. Anything outside of what's being covered in those clinical documents that are that person's there for treatment for at level 3.1, treating at the substance use disorder location, behavioral health, short-term residential, that would be included in the bundled rate and billed under the PT93 group with the individual provider who has oversight to the program or the individual provider who has oversight of the treatment for that. Does that make sense? Anything
Yeah, it
outside
does.
of those specific services wouldn't be.
So hopefully I'm allowed to do this, but Beth, I'm hoping that I can share this, but this is a draft of what the billing guide will look like and who can provide the services under each code. So I know, Jennifer, you're asking specifically about like getting a kickback or an audit error or something like a perm audit or something like that. And I'm not sure if I can answer that question, but I know that the services that can be rendered for these particular codes, the providers who can do those are listed here on the right. So these will be added to that grid that's in the billing guidelines. So if that helps answer the question, otherwise, if it doesn't
Yes,
qualify, go ahead.
I totally understand that part of it. So, like, we would bill under, let's say, the primary counselors or clinical supervisors, MPI. What I'm just trying to determine, though, is like that I'm billing under somebody who is a Medicaid provider under provider type 93 linked to step 2. But every service that they receive that day is not going to necessarily be, or does it have to be, or I can't bill for that person at all?
So I'm not sure if that's going to be covered in the MSM policy. I did see like documentation requirements, so that might help clarify for you. I don't know that I can answer that question today. It might have to be taken away as a takeaway and follow up with you.
Perfect. Thank you.
And Jennifer, I do have your email address, so we can talk about this. And it might be a question for all of our providers, but I don't think that I can answer that today, unless Beth, you are understanding and maybe you can chime in. But otherwise, I'll have to do it as a takeaway.
Jennifer, I think I understand the intention of your question. I have some additional questions I need to take back to my leadership to get clarification before I provide a firm answer to you. I'm hoping that we'll be able to have, we can bring this discussion up at our Thursday SUD provider call Thursday morning. So hopefully we'll be able to have some, I'll be able to have some feedback for you then.
Awesome. Thank you.
Okay, and I know we have one other question in the chat about level 3.5 and the hours. So I'm going to jump into the MSM policy because we are running short on time. I just want to make sure that we are covering some of the highlights for policy. So to get to policy, if you're not sure how, you can either access it through the billing guideline and click on the hyperlink there. It's chapter 4100 under the Medicaid Services Manual, or you can hover over quick links and just jump over there this way. And then once you get to the Medicaid Services Manual page, we're going to scroll down till we find our MSM 4100. And we'll click on that hyperlink there. You'll always open the very top hyperlink that says current and whatever date. So that's the policy we're going to be looking at today. And we are going to cover some of the highlights in this particular document that I think are pertinent to the prior authorization pieces. So to jump right in, we do know that we have all of our specialties for our groups. We have our 704 specialty with the subspecialty of 713. That's the only one that's available. We have our 707s with all of the subspecialties of the ASAM levels at 7, 10, 11, 12, and 13. That's your outpatient level 1, your level 2.1, 2.5, and 3. Level 3. And then we have our opioid treatment specialty with all of the subspecialties of ASAM level 1, 2.1, and 2.5. So depending on how you're enrolled and what subspecialty you chose, you're going to follow the criteria in MSM 4100. And so I'm going to go ahead and just jump right to the different ASAM levels of care in here. And the first place when it goes page 30, I believe. Just go to page 30. I'm going to have to do that. So when I say page 30, I'm talking about the PDF document page 30, not the page that's listed down below here. So when I'm talking about those page numbers, if you're taking down any notes, it's the page number of the actual PDF document. So over here on the right-hand side, you'll see page 30. So when I do ASAM level 1, here's the criteria for the ASAM level 1 services. What would be covered under that ASAM level 1? So that's all listed here on these couple of pages. Prior authorization requirements for level 1 is listed here. So that's anytime your service exceeds that service limitation. When it's not required, you have your service limitations lined out here for your psychotherapy. You have peer support service limitations here, and then what form you need to use. And then the authorization period for level 1 is for 90 days. So for your continued service request for ASAM level 1 for any of these services, it would start on day 91. You would have to have that concurrent or continued service request submitted prior to that 90th day that you were authorized through. ASAM level 2 is your 2.1. That's your intensive outpatient. That is consistent of 9 to 19 hours per week for adults and a minimum of 6 hours per week for adolescents, and at least 3 days per week. Then we talk about what some of the criteria are down here in this page 32. And then it talks about clinical service provided by formally affiliating external addiction treatment providers and programs may count toward the total hour of weekly clinical services if care and billing are coordinated and documented. So I think that helps with some of the outside services that might be included. Then 2.5 is also level 2. So this is for 20 hours a week, at least 20 hours a week for 5 days a week. And then if we keep scrolling down, it talks about how long these authorization timeframes are for IOP and PHP. I'm just going to keep scrolling here. Then it talks about the covered services under ASAM level 2. So you have all of these services here. And then 2.5 and it's up to 90 days. So that's on the bottom of page 34. Okay, and then scrolling down some more. Oh, sorry, this is for 2.1 is valid for 90 days. 2.5 is valid for up to 3 weeks. So your continued service request would occur at the 91st day for IOP and for that beginning of the 4th week for PHP. And then your ASAM level 3. So that seems to be the biggest question that I've been getting since it's new to the fee-for-service program and our MCOs and for providers billing. So I just want to cover some of the highlights in ASAM level 3. And that starts on page 35 of the PDF document. Room and board is not reimbursable to Nevada Medicaid or through Nevada Medicaid. So you are only billing for those bundled rates for your ASAM level 3 services. So that's your low intensity residential. This is the criteria for that. And then it talks about the 9 to 19 hours of clinical services per week would qualify as your 3.1. Yes, 3.1. And then 3.5 is going to be at least 25 hours per week with this criteria here listed here in section B. And then your 3.7 withdrawal management, that is 24-hour, it's 24-hour evaluation and management, and then these other services as well. They are for observation, mostly monitoring, and do not require full acute inpatient admission unless if they meet that criteria for that. So the level 3 covered services for all of these 3.1, 5, and 7 are listed here below in number 2. And then your prior authorization request requirements. You need to make sure that you are including for your level 3.7, since it's listed here first, that does require the psych evaluation within 72 hours of that admission to your residential for that level of care. Those authorizations are valid for up to 5 days. You can do your continued service request at the 6th day. You want to make sure you're submitting it prior to that 5th day. And then 3.5 is valid for up to 30 days, as well as 3.1. So your initial request is for 30 days for the 3.1, 3.5, and then only for up to 5 days for the first initial request for 3.7. Okay, so now we're going to talk about the withdrawal management and treatment services. That's your level 3. Here's your coverage and limitations for those services under each one of those levels of care. We do reimburse for those services in an IMD setting or for outpatient settings for level 3. That would be under the 707 specialty code and enrolling as a residential level of care. It gives you the age criteria here in this section. Talks about the withdrawal management for substance use. Here's the criteria for those reimbursement criteria. It looks like we would reimburse for up to 21 hospital inpatient treatment days with unlimited, that's okay. So that would have to be, again, authorized for approval for medical necessity. Here is the requirement for prior to admission in this section here, page 39. And then number 4 is the one that I want to bring attention to, because I know we just had a review where the first initial request was submitted for 5 days, and then the psych evaluation came in after they submitted the request, which is fine because we have 5 days to review those. So by the time you get that psych evaluation uploaded to the PA, we would have the psych evaluation documented there, and we wouldn't have to pin it back to you for that information. So that's just one example of a 3.7 PA scenario. You're going to do it for your first 5 days. If you don't have that psych evaluation, you have that 72 hours to do it, and then upload it to that PA number, which would be there and ready when the nurse reviews it. The psych evaluation is only valid for the 3.7. We are on level 3.7 here in the policy. That's right. Yeah, so 3.7 is our only withdrawal management level of care. And that's section 4107, and we're talking about A and then B4 on page 39. Okay. I know there's a lot of questions coming in the chat. I am going to, I think the best thing for me to do right now is kind of break and maybe answer the questions that we have. We might have to take some of those away and follow up with you. We are going to have this recording available for providers again, like I mentioned, on our YouTube channel. We will also have a questions and answer document that we'll post out there to our provider training page. That is being built as we speak. And so we'll take some of the questions from here and add that to that question and answer document. I'm going to close out policy and show you how to get to the YouTube channel on our provider training page so you know how to get to those resources. So from our main Nevada Medicaid website, you're going to hover over the word providers and drop down all the way to the bottom of provider training. And when you get here, you'll scroll down to the middle of the page here, the self-paced training section. This is where our YouTube link is. We'll go ahead and click here. You can see the YouTube channel. You want to make sure you subscribe so you stay up to date on anything new that's posted out here. If you go to the playlist tab, you'll see actually you have to go to the videos tab, I apologize. You'll see our substance use enrollment workshop video. We will post the enrollment workshop that we just did last week, as well as today's PA training out here on this videos page, videos tab. So you'll be able to access those resources. And then going back to the training page, if you scroll down a little bit further, you'll see our provider tip sheets and quick reference guides. We do have our PT93 linkage document. Sorry, it's under the workshop material down here at the bottom. So this is that linkage document that I showed you that was attached to the web announcement that shows the linkage for providers and who can be clinical supervisor. We'll also post the Q&A out here once that's developed and fully approved. I don't anticipate that'll take too much longer to get finished and finalized. So we'll post that here under the provider tip sheets, quick reference guides, and FAQs. So with that, I'm going to go ahead and wrap up just because I know we are at the hour, and see if there's any questions that if you want to stay on a few minutes longer and kind of go through those, or if you just want to have me follow up with you, we can certainly do it that way. All of our chat messages are recorded so we can know who asked them and who to follow up with. So I will leave that up to you. I do appreciate all of you coming today. I know it was a lot of information to cover and we didn't necessarily get all of it addressed. We will, if we have time or if there's a need, we will have additional PA training workshops once we are able to schedule those probably later on this month. So look for follow-up emails from me. And then I will also be posting out web announcements. You could also email Beth Scott. She just posted her email address in the chat. You can always email me directly as well, since I am the representative for PT93. I'll put my email in the chat. And then I will leave it up to you on whether or not you are ready to drop off the call, or if you want to stay, raise your hand, come off mute, put your questions in the chat. We would definitely encourage anybody to stay on for a few minutes at least to go over any questions. Deanna Torres?
Hi, so we had put, I know we're kind of running out of time, but a question in the chat, and it looks like somebody else had asked that question or at least didn't get an answer. How can we verify and get that answer or get that question answered? So it was on what's the difference with the clinical hours versus structure?
That is not something that I can answer today. I will have to get clarification from policy and the intent of policy to get that for you. So we will have to follow up in an email. Like I said, any questions that didn't get answered in the chat, I will be following up with you individually so you can get those answers. Okay.
Okay. Thank you.
You're very welcome.
Jennifer? I did take that question down as well.
Okay, thank you.
We have a meeting tomorrow, so I will take that question back as well and see if I can provide an answer for you on our Thursday call.
Perfect. So we do see that those requests on who is requesting the clarification. So we will be following up with you with that response. Whoever put a question in the chat, like I said, it is recorded. We know who asked and what the questions are, so we can follow up with those individuals. And if it's a commonly asked question, we'll answer it, or we'll put it on the QAG or QRG or FAQ that we're going to be posting on our provider training page. So just so you know, your questions are not going to go unanswered just because we ran out of time. And I don't see any other additional hands up. So having said what I just said about the follow-up and knowing that we are over the hour, I'm going to end the call, the presentation today. And again, I want to thank you so much for coming out here and going through this process with us. As you know, as I mentioned, it is a new service for us for the level 3. So we will be addressing those questions as they come in for everybody. And then anybody who asked a question again on this call, we'll make sure we follow up with you. And then a big thank you to Beth and Alyssa and Joanne and Tracy for being here to support me today and to support our providers. I appreciate your guys' assistance and for jumping in.